of Monro. It's cystic or solid. Commonly, these patients have a permanent or intermittent headache, so they have a clinical sign of increased intracranial pressure. I think the most important thing is you have to know is that this might be intermittent. So very, very frequently those patients are symptom-free, and then they have a severe headache period, and then they're symptom-free again. So, and there's at least in my knowledge, about 1 to 2 cases a year in Germany, patients die of this disease without, ever have been diagnosed. So acute occlusion of the foramen of Monro is well known, and this is always then a really life-threatening emergency. So when there's a distinct size or a risk of occlusion of the foramen of Monro of these lesions, or they are symptomatic, we do surgery on all of these lesions, or they are symptomatic, we do surgery on all of them, or we recommend surgery in all of them. Doesn't have to be that they have on the MRI really hydrocephalus. If it's a certain size of colloid cyst and it's, well, feasible to see that this is going to occlude the foramen of Monro, then we recommend surgery. Okay, so what are the techniques? We can go cortical, microsurgically. You can do transcallosal, interhemispheric, and you can do endoscopic. Well, who does these lesions endoscopically? Oh, very many. Who does it open microsurgically? 50-50.
There's an overlap.
It's an overlap. And when you do those microsurgically, you go into hemispheric or transcortical? Interhemispheric. And who does transcortical? None. Okay, interesting. 1, 2. Well, I think the interhemispheric is a nice approach, but I don't like it that much because you really have to pay attention of all the vessels. It's more time consuming than transcortical. Transcortical approach is very fast and forward. They're there in 3 minutes. Anyway, so when we have interhemispheric, it's a very standardized. I think this is the most well standardized approach for the third ventricle lesion. There's minimal brain parenchyma dissection, particularly if you put the patient in the ideal position. There's a minimal brain retraction, and you have nice space for bimanual manipulation. We have a direct view at the tumor origin, so the roof of the third ventricle. I think this is a big advantage. So it has some advantages to use this approach. Well, fornical lesions are very common in this approach, and I know that all those who use this approach will disagree, but based on the literature, there's up to 80% by fornical lesion, even bifornical lesions well described. So particularly if the fornix, they stay very close together, I would not do this procedure. I only say what I would not do. I don't do this procedure then. If they are pushed apart by the lesion, that's a completely different issue. Transfrontal microsurgical, I like this very much because it's a fast procedure. It's well known. You just do this standard burr hole, then you increase this a little bit, and you go basically exactly transcortical you used to do with any EVD or whatever. It's a bimanual technique, so this is much easier. But the disadvantage is, I think, you don't have a direct view of the tumor bed. When you do transcortical, there's no way you have a direct view, microsurgical view at the roof of the third ventricle where this attachment of the colloid cyst is. So there might be significant contusion of the fornix. Well, also you say when you do this, well, I don't see anything, but just try next time when you do a microsurgical case, transcortical and transforaminal, then go in at the end with an endoscope. And you will think that this is a major disaster because it's a magnification of the endoscope. You think you do fornical lesion with the endoscope, you have no idea what you really do with the microscope. It's much worse. So this is the transfrontal endoscopic technique. It's the most minimally invasive since you have the less small burr hole. You just go with the endoscope through the cortex. And well, there's also some manipulation of the fornix. I would not say that there's no confusion. You might have nice cases, but the majority of cases you have to have some manipulation, but it's not a significant confusion. And you use particularly the angled optics, they have a direct view at the tuber bed. Disadvantage, no bimanual technique. Well, you can argue you can use two instruments with the endoscope. Actually, the first one who did this was Gab. Gab used with his endoscope, you can use the irrigation channel for a flexible second instrument. So this was originally his idea to grasp the tumor and then cut it with the scissors. So you can use this with a Gab endoscope, with a Lotte endoscope, I think. But you still cannot really, you can just pull a little bit. This is the advantage of the second instrument. It's not that you really have a bimanual technique, because you cannot really manipulate with both hands independently. Venous bleeding is quite frequent, at least we have it, I think we have worked it up, I think it's 90% of the cases we have some venous bleeding, which is annoying. And the technique is more difficult than open microsurgery. I think that is for sure. So I would recommend only rigid optics. I have no idea if anybody does this with a flexible, I'm not aware of. I think it's nice if you have angled optics for inspection of the roof of the third ventricle at the end. And well, navigation, if you're not familiar with the approach, navigation might be helpful. And there's a continuous discussion about the entry point, ideal entry point. I think there's no doubt when you want to have a look at the roof, you have to be a little bit more lateral, because the approach for the floor of the third ventricle is as close as possible to the midline, so ETV. Okay, we want to have a straight approach to the midline floor of third ventricle. But here, we want to have an approach to the roof of the third ventricle, so you come more lateral to have a good view, as good view as possible. Then some say you can stay a little bit anterior to the coronal suture. Some say you stay a lot anterior to the coronal suture. Also, this is it has both approaches have some advantage. I think the most advantage is if the more anterior you come and the more lateral you go, the easier it is to really see the attachment of the colloid cyst at the roof of the third ventricle. And initially, I always said you have the microscope ready. I don't say this anymore, but you have to have the skills to remove this lesion if the endoscopy fails. This is so microsurgical skills are more important. So this is an idea of a lesion. So this is a typical colloid cyst. You see a significant hydrocephalus, and this is a more difficult colloid cyst. You see it's a little bit more posterior. Here's the foramen of Monroe, and this is the approach we use. Some intraoperative images. This is a right-sided approach. You see this is a nice colloid cyst bulging in the lateral ventricle. Then usually copulate the cyst, and then we have seen some images in the, I think, first talk today. You decompress the structure. You can aspirate sometimes, and then you use irrigation, and step by step you remove the lesion. The most important thing is to detach the lesion from the vessels, and this is sometimes it's very difficult, sometimes it's very easy. So sometimes you can really cut the lesion from the attachment, but it's not always the case. So this is a typical here. This you can then cut if it comes out nicely like this. You see that this colloid cyst really came in toto, and this is then the roof of the third ventricle. Inspection with the 70 degrees optics, you see that there's complete resection. You can do at the end a thorough inspection of the third ventricle. I always do this, and you see when you see the data now that we do a lot of additional ETVs in these cases, because when you look at the aqueduct, and I see some random blood clots here, which is frequent because you have venous bleeding almost all of them. I prefer to do an ETV. I don't leave an EVD in most of the cases. ETV in this takes another maybe 3, 4, 5 minutes, and you restore, you make sure that you have a nice CSF flow, And because this blood clot removal here is very challenging, and I think the risk of trying to get this blood clot out at the aqueduct is much higher than the risk of doing an ED.
You do a septostomy systematically or not?
Septostomy not, no. Septostomy not. This is the inspection here of the contralateral foramen of Monroe. If you have 70 degrees or 30 degrees optics in, you go on the third and you see that this is the contralateral foramen of Monroe. It's wide open. There's no reason for septostomy. Okay, so this is a typical post-op. Let's see if this video runs. Yeah, no, don't, you know, we have to be patient. Otherwise it stops running. So it's a typical case. I think it's important to shrink the lesion. If it's very firm, this is not the case in this case. If it's very firm, you can aspirate most of this, 90% of the lesion with the nasogastric tube, like from neonates, so the smallest one available, fits perfectly well, at least the GARP endoscope, and then you can just aspirate the lesion. It's very easy.
You haven't used the Cavitron yet in any colloid cyst?
I don't know. I might have used it in, I don't know, we discussed this. When did we discuss this?
Yes, in Istanbul. I was strongly in favor of Cavitron.
I don't think that I have used it.
Okay.
I don't think. It would be a nice idea, but actually the advantage of the Cavitron in this lesion is not as big, as significant, because when you use the tube, this is an avascular, the content of the cyst is avascular. So to use the tube, it's very easy to suck it away. It's not a tumor in this perspective. Okay, well, this is the post-op, and this is our follow-up. We have close to 60 cases, 57 patients. There were capsule remnants left in 6 cases. There were small cysts left in 2. So far, there was no recurrence. Venous bleeding, you see, it's 55. It's even more than 90%. I just noticed. So see, in all of the cases, this happens. Venous bleeding means there's some venous bleeding. In 10 of these, it changed the surgical strategy. This means recurrent heavy venous bleeding. We call this because then you really stay there, you need irrigation for another 10, 15, 20 minutes. Sometimes you use the dry field technique to suck away the CSF. So this is changing our effect on the surgical strategy was in 10 cases. And in 1, actually, I switched to the microscope because, when you do this the 3rd time and you still have venous bleeding, and then it's amazing. You go in with a microscope and this is not noticeable. What you were struggling with before was just, you would not notice. You do not recognize it as a significant bleeding. It's nothing. Very interesting to do this. We have done ETV in 40 cases. 4 actually needed a shunt in the long term. They did not recover from the symptoms, so they probably for the fluid content or something they had to develop moderate soft diphtherocephalus. This is the complications, and there was a transient cyclosyndrome, I think probably because there was one case where there was heavy bleeding, but not the case we switched to the microscope and 2 patients suffered from tinnitus just because of the perioperative stress was resolved. So I think colloid cysts are good candidates for an endoscopic approach. I think it's quite difficult, an endoscopic approach. It has some advantages because I think your more preservation of the fornix is easier with the endoscope, and I think you have a nice view of the roof of the 3rd ventricle. But, there's a significant risk that you have to switch to the microscope, and I think it's quite difficult. Thank you very much.